All right, hello and welcome to today's webinar for mental health professionals, empowering families in the face of pediatric acute onset neuropsychiatric syndrome by Dr. Lynn Sicklin and Dr. Tamara Chansky. My name is Astrid Masvar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's audio system by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. You may also download today's PowerPoint presentation by clicking on the Materials tab on the webinar platform. You'll also have the opportunity to submit text questions at any time during the presentation by typing your questions into the chat box of the control panel. We will collect these and address them during the Q&A sessions throughout the presentation. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the very end of the presentation. You will receive a follow-up email, including the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credit. You will also have the opportunity to complete the post-test assessment after the presentation. The questions will appear on your screen, and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Sicklin and Dr. Chansky. Dr. Lynn Sicklin is a psychologist at the Children's Center for OCD and Anxiety in Pennsylvania. She has been specializing in treating anxiety disorders in children and adolescents for over 20 years. Dr. Sicklin enjoys assisting parents and teens through the transition into young adulthood, maintaining connections and closeness with encouraging and building autonomy and competence. Dr. Sicklin conducts training workshops for professionals and parents, as well as offering consultations to professionals. Dr. Tamara Chansky is the founder and director of the Children's Center for OCD and Anxiety and the author of Freeing Your Child from Anxiety, Freeing Your Child from Negative Thinking, and Freeing Yourself from Anxiety, a book for adults. Dr. Chansky lectures to parents, psychologists, and educators regularly on how to make anxiety treatment and prevention kid-friendly, effective, and easy to implement. I'm now going to take a moment to pass the screen to our expert. There will be a brief pause while I do so. Perfect.
Welcome, everyone. I really appreciate the opportunity. Thank you, ADAA and Lynn, for working on this presentation. We're really excited to have the opportunity to talk to you about PANS today. So there was a little learning curve for me and for us doing this webinar today, and it brings to mind that one of the crucial issues for families facing PANS is that the learning curve, there isn't the, when families come to us for treatment of anxiety, depression, OCD, generally they've had time to get used to what's going on, and then one day they decide, hey, it's time for treatment. And they're just a really important part of the picture, the clinical presentation really for families with PANS, is that there is no training time. At the moment that they need help, that they are just, this just happened yesterday. And so their ability to parent in the face of what feels like an emergency situation, their child's writhing on the floor because they don't know if, their cup touched something else, are they going to be poisoned? And they've asked you that 100 times already. And while that might happen with a child with OCD, the parents have gradually been trained to that point. It's not as alarming. With PANS, this is the initial presenting picture. So they have an emergency on their hands, they have no training, And then they encounter another obstacle, which is that they may go to a practitioner who doesn't know what's going on. So usually when a parent seeks treatment for their child for depression or OCD, practitioner can be very calm and reassuring about, we've seen this thousands and thousands of times before, and this is what needs to happen. And so for a lot of parents, whether their first stop is a pediatrician or a therapist, they may have the additional hurdle of folks saying, you know, we don't know what this is, or even if parents have done their internet researching and say, but I think it's pandas, they may encounter the point of view that practitioners don't believe or are unaware of the syndrome. And so this is the starting point for a lot of parents. And so even just signing up for this webinar today, you know, many people may have had experience with treating families with PANS, or if this is your first encounter already, you're going to be able to do more for families because this is on your radar. And if you don't know everything about it, we don't know everything about it, it's an emerging field already, you're going to, just by your awareness, allow a life-changing process for kids and families to happen. They will, first of all, be able to exhale in your presence because you will be the first person potentially who says, this is something that we know about, you know, we're going to help you with the steps that you need to take to get your child back, because in that emergency, what parents feel most of all is that they've lost their child. So let's head into the presentation. So do I just, okay. No.
Astrid?
That learning curve, excuse me. Also
Yes.
dealing with it.
It's not letting us advance the slides.
Oh, are you using tomorrow's webinar?
I think we might have figured it out. No?
But now I just
there it is.
lost, but I lost us, but that's okay.
We're still on camera, I think.
Okay. Yeah, can't see the camera anymore, but that's okay. So there are a lot of similarities. I'm going to keep going here. It sounds like we may have lost a soundbite there, but there are a lot of similarities in the therapist's role, even with a very different situation of PANS. But I want to create a foundation here, just quickly run through, you know, what is our role as a therapist when we are working with kids. Parent, you know, whatever the situation is, parents are coming in not understanding, kids are coming in not understanding what's going on with them and what to do. And so our role is to empathize and translate the frightening experiences that people are having into a coherent narrative. Again, an essential point of this is knowing people have been here before. This is something that is known, and you know, there is a way forward, and presenting the treatment options based on the current knowledge in the field, and we'll describe that in a second, what that current knowledge is, referring for medical treatment, and presenting the CBT model, so that people understand this is an active therapy, that in a positive way, it's a project that kids and parents will be working on to change their relationship to the thoughts they're having, change their behavior in response to those thoughts, and in that way really change their brain, setting a new pattern. And additionally, coordinating with schools to educate the school about what's going on. This is going to be especially important with PANS, as a lot of kids aren't able to go to school for a period of time, and or need to have much less work to do because of focusing and other cognitive sequelae of having PANS. So we'll talk about that in a minute. And I'm going to just go there. also, importantly, even though, we're kind of heading to the punchline here that PANS happens to a child, it's an illness process within a child, that there are going to be jobs for everyone as the symptoms impact everyone, and that is part of how we approach working with kids anyway. But throughout this process, offering thinking in stages, with PANS, I will say to families, this moment where you don't have, your next steps together yet, this is the hardest time, and it won't always be this way. And offering that hopefulness that, again, others have been here before, and that things will change as they get on the right path for treatment, emphasizing the no fault aspect of symptoms. Folks who work with OCD experience this already. Especially is important with PANS, that kids are having all of a sudden thoughts that are so embarrassing, and they're ashamed. And so right away, letting them know that they're no bad guys. This is not their fault, that the thoughts really aren't, it's not a Joey thought really, or a, Sally thought. This is just what these thoughts are like. This is what they sound like. They're afraid that, because they had a thought that they hate their mom, or that their dad is fat, intrusive bad thoughts that kids have, or intrusive sexual thoughts, hitting the family all of a sudden. It's really important to begin that process of separating the thought from the child, and making this more of just kind of a universal experience of this is what it sounds like when you have PANS. Preparing families for reasonable expectations for the future. In a first session, parents will say, is this going to go away? Is there a cure? And letting families know that that there are treatments, that they will get their child back. It may be, more straightforward process. It may be more complex, but that lots of people are working on this to, identify effective treatments for their children, and that is what's going to happen. The future exacerbations, as with any anxiety or depressive symptoms, there can be setbacks. With PANS, there can be setbacks if a child gets sick again. Importantly, and putting that hopeful sense in, that this is the hardest moment when everything's new. Mm-hmm. They've just found you, and they're so glad to have found you because you understand what's going on. Then they need to identify, a medical practitioner who's going to help them. So they get their team together. If there is a recurrence, they have their team assembled. It's really a different experience.
Right. Just to say, we never go back to square one, right?
Okay. And so folks
People
may
were
have
asking about. Sorry, one question came up: is PAN and PANDAS the same thing? So you could discuss that.
Right. So yeah, we started out with PANDAS back in, I guess the first paper I think was in '89. Might have been a little bit after that the acronym came. I can't remember, but the pediatric autoimmune neuropsychiatric disorders associated with strep.
Yeah.
So initially the understanding was that, based on, if you look at the slide, long history of viruses and infections that cause seemingly unrelated psychiatric symptoms, there is precedent for that. But Susuito was seeing kids who had strep infections and then obsessive compulsive symptoms and tics. So the first group was really about strep. So that's how the PANDAS acronym came about, that this was the unique relationship they were studying. However, very soon after that, and probably even around that time, because I had one of the first patients in her study, a kid had Lyme disease, than other kids had, post-vaccine reactions or pneumonia reactions, things like that, where the same pattern of a child was sick and then this sudden overnight onset of OCD symptoms, tics, or refusal to eat. And so over time, there was this refinement that came about, that the pediatric acute onset neuropsychiatric syndrome was the umbrella for this pattern of sudden onset of symptoms that could be caused by a number of different medical conditions. Importantly, and this is a tool that we are non-medical people, and I will freely admit that, and do when I talk to pediatricians, that there are a group of experts working in the field of pandas and pans brought together 3 papers in 2017 that I believe they're at the end of our presentation, the links.
Right, these are going to be an essential guide for you in working
so
with
there's different, and the reason why, you can read them, I've read them, highlighted them, but the important, that will be helpful. And it may also be helpful that when you have a patient and you need to advocate or collaborate with their pediatrician for testing or treatment, that you can say, as I do, I'm a non-medical person, can I send you these articles? And it's so helpful to have this tool that, is in a recognized journal and respected journal, and then the physicians can look at that and make their decisions. Okay. So, okay. Lynn will, keep me on track here. Okay, so OCD versus PANS, what's the difference? So very simply, I call PANS exact date disorder because they're, unlike the gradual onset of OCD, people come in and say, when they were this age, this happened, this age, this happened, now we think we need to do something about it. That's not PANS. Parents say they can really identify the exact date when child that woke up the next morning, it was like their child was gone, because the OCD symptoms or tic symptoms or refusal to eat, emotional lability, all the symptoms I'm going to identify, I think, in the next slide, came on like that. So when you have that sudden and extreme onset, that's the first thought of, could this be PANS when you were doing your differential? Okay, so what is important here is that not all symptoms need to be present. OCD symptoms for sure, as I was talking about earlier, intrusive bad thoughts suddenly appearing, a variety of motor or vocal tics can, again, appear suddenly. Separation anxiety that is different from what the child manifested before. Kids can have OCD, kind of like at a 4 or 5, and then they still can have an exacerbation from, PANS, and you will see a spike in all those symptoms. So it's okay. Parents might say, well, they had this before, but it's out of control and it happened, kind of overnight. We would still do this as a rule out. And
we're going to do some cases that kind of illustrate this, because this is where it can get tricky.
Right. So, so we have here, in addition to OCD, anxiety, separation anxiety, tics, restricted eating. Kids will literally stop eating. It's not, picky eating. It's not really like that. They're afraid to eat. They won't eat and they won't drink. And it becomes a medically, urgent situation if that is the case. Other characteristics that can be present: change in personality. A very compliant child becomes belligerent, talking back, oppositional to parents or siblings. hyperactivity. They're just can't sit still, can't sleep. Cognitive and memory changes. The case that I'll present in a second, excellent student, loves school, could not sit and think, could not do schoolwork at all. Sensory and motor symptoms. I've had kids where they can't put on their shoes, they can't put on their clothes. It actually feels painful to them. And then emotional regression frequently, this is what parents will come in with videotapes of this, because they're just incredulous. They're so scared and don't understand their child was not like this before. Rages, crying, tantrums. Also, enuresis, child who was fine with, toilet training, and they could be 6, 8, 10, whatever age, and suddenly they're having accidents, they're having urinary urgency.
And just to know, pediatricians first recognized PANS partly by the urinary things that were coming to their office, so that's helpful. Someone is asking here, I think a question that you're kind of answering, but I think it's people confused. What about children who have a history of OCD anxiety tics, but then have the acute or sudden onset following strep or another infection? Is that still defined as PANS?
Yes.
Right. So that's a tricky one and a good question. But,
yeah. So it's really, you look at the process and the intensity that you would want to do that rule out if the trajectory sort of, where the level of intensity of symptoms suddenly spikes. And even if there are not, the child doesn't present as sick, sore throat or anything like that, you really look for that change of behavior, that spike in OCD symptoms, you would want to send them for testing. Actually, in an early paper of Dr. Sweeto's, there were no classic sore throat symptoms or fevers in the kids who had PANDAS at that time. So, but what there was this spike, this sudden appearance of OCD symptoms.
And it's tricky, and I'm going to present 2 cases where I thought it was not PANS, and I found out it was.
Right.
For that reason, because of the history in the past.
Right. Okay. So I'm going to,
right.
Yes. So quickly, I'm going to talk about just psychoeducation. I did already start this earlier, that you want to reassure the whole family if you have this sense that this is what is going on. Child has a wonderful brain. Sometimes the brain makes mistakes, and that's what's going on here. So you want to do that separation to say, you're part of your brain, and kids sometimes will come in saying this, my brain is telling me, or that thought is telling me I have to, and it's great they've already done that separation, that you let them know that, right, we're going to, those thoughts sometimes happen when you have, strep throat or some other kind of sickness that's treatable. You're going to get better. Really important to say that. But this is the way it plays out, is that it just gives you all these thoughts. So there are going to be 2 parts to this. It's going to be, the medicine that your parents are going to help you with. And this is a conversation I'm having with the whole family, or the parents and the child. And then the other job is that the child and the parents are going to learn to try to not get tricked by these thoughts, to do something different when the thoughts come, instead of just kind of following them and doing whatever they say, that they're going to start to boss them back in specific ways.
This is a great point. I would just point out that, reminding them that until a month ago, right. So
you'll
hear
were
differently,
right? In the cases that I present, that one strategy that is very helpful to kids is to kind of last year it, to think, if I were, or last month in this case, last month, if I thought about, my shoes, would I be worried about what was on the bottom of my shoes? No, and I was a lot happier. We're going to work on last monthing it, to skip the ritual. Okay. Okay. So the medical treatment, and again, we need to know about this to an extent so that we can get parents on the right track and advocate for them if these things aren't happening. The detail here is, not at a level that for medical professionals, but as mental health workers, that, this is what we need to know, is that these are the professionals who could be consulted for assessing and treating for PANS. Even if there isn't positive lab work, and we'll look in the next slide at what the lab work may be, that either antibiotics or antineuronal treatment may be helpful. But if there isn't a current infection, that ongoing prophylactic treatment with ongoing antibiotics would not be indicated. Okay, so these are some tests for determining if there is, a strep infection present or other. So, the throat swab, the titers that are, the strep titers are the ASO and ADB. They can be repeated in 2 to 6 weeks if they are negative, to see if they have changed. There are other, as we've said, there are other sources of the autoimmune reaction that can occur, such as pneumonia. And so those tests would be done to Mycoplasma pneumoniae would be done. And these other tests could also potentially be done, but in terms of assessing for PANS, it really would be primarily the blood titers, and the throat swab.
And this table is in the guidelines that we were saying is so useful. And this is a table that I have sent, the table alone, to pediatricians as a guideline for testing. And they've really appreciated knowing what is the protocol for testing. So this table can be a very helpful resource for you to have, not to tell the doctor to do this, but to suggest that this is the protocol or guidelines for assessment.
Okay, and so the treatment options, just for the array to be aware of, for mild to moderate symptoms, the recommendation, and this is from the 2017 guidelines, CBT, antibiotics, and because the process that happens in PANS is the autoimmune reaction, means that the antibodies for whatever it is, strep or pneumonia or whatever the source may be, are attacking the healthy tissue in the brain and causing inflammation. And it's the inflammation that causes the OCD symptoms, the tics, the behavioral changes that ibuprofen and sometimes steroids, you see in the next section, are used to reduce the inflammation. So with moderate to severe symptoms, disrupting functioning or weight loss, CBT, the immunomodulatory treatment with modulatory treatment, IVIG, plasmapheresis, steroids. And there are other treatments as well that are in the guidelines, which are used occasionally. And I just want to say that much of the time, the kids, and I've worked with hundreds of families with PANS, and I know you've worked with a lot of families with PANS, much of the time, CBT and antibiotics will do what needs to be done.
I've never had an IVIG case. I know Tamara's had more intensive. I've never had one that, I had one who was doing it but when they came to see me. But so I think to say a lot can be done often on the less severe cases with the mild to moderate symptoms.
So, okay, why don't I do this? I already talked about this to an extent, that our role is to facilitate the connection with a pediatrician. We have these resources. We can say, I've often said, look, I know the child's not sick, but this is what's going on behaviorally. Can you do this for me? These are the guidelines. You're willing to just do a strep test, and usually they are willing to do that.
Yeah, and I think Tamara's saying really important. I think respectfully approaching the pediatrician. I can't believe that almost every pediatrician has gotten on the phone with me to have a quick conversation about helping. But if you send the family alone to do it, it's too hard.
It really
it really is
helps
too hard.
yeah,
They can
just
start
to
it.
offer to say, you know, and tell the doctor. If sometimes I'll say I can't call till tomorrow, tell them that I will.
Right.
But just sort of saying that your psychologist is supporting, you know, this this hypothesis that they are willing to take the steps.
And we'll come back to it if we have time, but it's probably another talk. Some people don't know about it, medical professionals, and some people question the PANS, and maybe we work with the family to actually work with a different pediatrician if we need, if there's either hostility or resistance, but it's not the norm.
Right. Okay. Okay. So I'm gonna talk about quickly 2 cases where what you'll find is in this presentation, and Lynn has very different cases, which is great,
Yeah.
that I did need to do, you know, so first line of treatment is CBT along with these medical pieces. If it's a medical condition, what is the role for CBT, except that you can work the change from both sides. The medication is helping reduce the, you know, the infection and inflammation. And on the other side, because we know that, you know, behavioral patterns reinforced just get stronger and stronger, we can begin to shift to parents not answering a question 100 times, kids beginning to say, you know, instead of confessing, they say, I have that confessing feeling, and the parents can say, okay, thank you for telling me, let's boss it back together. So you start to do that same process that you would do with a straightforward OCD case. That's going to be helpful here too, to the extent that they're able to do it. So that's an important expectation, is that as the child improves, they will be able to do this more. It may be in the beginning, they can't do it that much.
Yeah, so asking a kid with very bad flu to actually do their exposures in the same intensity on that day, if you have a regular OCD case, the kid is sick, right? And they can only do what their energy, you know, and stamina allows, but they can do something, and nothing is not a good option.
Right. Okay. So, this was, I'm going to talk about 2 cases. And interestingly, so I didn't include the history on this case, but this is a child who probably had pandas without knowing it 2 years before this presentation, before they came to me, that suddenly overnight the child, they had a strep infection. It was determined. She was going to the bathroom, just staying in the bathroom for hours and wiping excessively. She, always felt like she was wet, and, just wouldn't be convinced. No reassurance would work that she had dried herself enough. And she was having other thoughts. Her dad was an alien, just, frightening things. But she was having some strep symptoms. So went to the pediatrician, 10 days of an antibiotic, all that went away. She then had pneumonia a year later. A year later is when they came to me, that all these symptoms came back. But the parents didn't immediately understand that it could be from an infection, because that had not been identified the first time. So we did, get her back on antibiotic treatment, which was helping. But here we had a child who was spending, it doesn't work right away. It's going to be, several weeks before you see improvements usually. So she was in the bathroom 2 hours each time, using 2/3 of a roll of toilet paper each time. So behavior therapist hat, what do? You try to immediately just limit down what it is that happens in the bathroom. Use a good explanation that we had a few minutes ago about this isn't you, your brain's playing tricks on you, but then gradually go from 2 hours down to 15 minutes, down to 5 minutes, down to how many pieces of toilet paper does she use? This is the nitty-gritty of our world. And she did really great with that. And the antibiotics were working at the same time. This is a child who needs no treatment. I haven't seen them. I saw them maybe for 4 or 5 sessions to do that work, support them through the treatment, and done. A second case, let's see. This is a 9-year-old who suddenly in church, out of the blue, had this weird thought. And it was weird because it was so normal at the same time, but it wouldn't let go. The thought, was up being part of a service, it kept telling him to think about, is this person pretty? Do I think that person's pretty or do I not? Ordinary thought, but when it just had a grip on him, wouldn't let go. It was very scary. And then it multiplied to many, many, many questions like that. Is this skin color better than this skin color? And he knew that something was wrong, but he couldn't stop it. He was asking, really, literally 100 times a day. This is the child who loved school, couldn't go to school, couldn't sit for any work. His CBT treatment was a little bit simpler. You might say, well, he was having bad thoughts, do exposure to them. He was being exposed to them 100 times a day. What we worked on with him was to use kind of a sarcasm response to say, thank you, brain. That's so interesting. That's so important. That helped to lower his anxiety some. And he went on to needing multiple IVIG treatments, but now he's doing well and he is back in school. So I know I have gone over my time, and I'm very sorry.
That's all right. So I think what I'm going to do is actually, can you just do a little bit on this, because I think this comes up. This is yours, just aggressive behavior. So, upsetting to families.
So what is our role to help kind of normalize what feels not normal, and teach parents how to parent in a very unfamiliar realm, because usually it's the really good obedient kids who are suddenly with this aggressive behavior. And so what we want parents to understand is that this is it's a no fault part of this syndrome is the disinhibition and aggression. It's involuntary, but they still need to be setting limits. But they're not, if a parent thought that a child was doing something intentionally, disobeying them, they might have a different response than if they understood that this was, really out of the child's control. So saying things like, I know this isn't you, but we can't, we have to do something to make sure that you stay safe and you don't hit your sister. So it wouldn't be punishments by any means, but they may need to separate kids to keep them safe, and being able to make a statement like, I know this isn't you, but we can't do this. We have to figure out how to keep everyone safe. That helps the child in the family system still feel like the parent's in charge. It's not all chaos. They know what's going on. They're dealing with it to the extent that they can. So that is, I think, an important part of this.
Well, maybe we'll have to see if we do Pan's part 2, because there's just so much to cover here. I'm going to skip ahead to the cases, because I think they start to illustrate the points we're trying to make in the overall slides. Tamara's already suggested that a lot of what we do is similar, right? Because much of CBT is about education and about the process and nature of anxiety. For these families, they're learning about PANS and about anxiety, but education is power, and it also guides kind of what we're going to do. A lot of times, as Tamara said about the aggression, can be used just about overall kind of parenting and managing. Parents, even if a child is really ill, can be modeling hope, a plan, and understanding of what's useful and what's not useful. So I'm here to help you get stronger and help make the anxiety weaker. I'm on your team, so I'm not going to follow the OCD or the anxiety rules. I know you will be okay if we don't. That's what we do, anxiety, OCD, all the time, but we can do it in PANS, right? Or you always felt safe in the house and moved freely. Nothing has changed except you're not feeling well. I know you'll be okay while I go upstairs, and the parent needs to go upstairs if the kid is separation anxious in response to the PANS. Or until you were not feeling well, you were able to eat with us and not check the food or ask me. It's still okay to not check now. Just to model like the OCD message, throughout, even if we can't do exposures in the same way, right? Because parents can still do it if kids can't do it right now. And I'm going to talk about 2 cases that tricked me, and I feel so fortunate to work with Tamara because I call her most every PANS case and go, is this PANS? Am I doing it right? I've gotten a lot better. I've recognized more, and it's been really some of my favorite cases to work with and to learn from. But they trick me a little bit each time, and these 2 tricked me, so I thought they were good ones to present. This was a 10-year-old with autism spectrum issues and ADD. He had a ton of GAD worry that preceded the diagnosis of PANS. The parents came to see me quite a while after the diagnosis of PANS. They had gotten medical treatment from a previous bout of the OCD and anxiety. He was on ibuprofen daily at the time, and he was being followed by somebody medically. He had actually been on an antibiotic course for 6 months because he had a pretty sawtooth, relatively rapid pattern where he could be well for a few months and then have a month of bad, and then for but I didn't see him that way. So I didn't think he was PANS. Someone asked in the questions, and we'll go into this if we can. The mom is a nutritionist. She had him on B12. They made changes in his diet from the previous year of limiting sugar and dairy, and it really helped him more on the ADD symptoms, but it really helped him overall. So someone was asking about naturopath and other treatments. So we'll come back. But for this child, it made a huge difference. And it seems with some kids, it can make a huge difference, and other kids, not so much. They came to see me with my specialty in anxiety and OCD. I'm just going to turn this a little bit so I'm on the camera. Yeah, maybe if that's okay. So I actually been seeing him for a number of months, just doing my regular stuff. And then he had a crazy 2 to 3 week spike in both OCD, and he became extremely dysregulated. Again, this is a really gentle, quiet kid, though he likes to have his own way. That's his norm all his life. And he began having wedding accidents in school. He's 11, right? So he was so upset and embarrassed because he couldn't manage his urinary functioning at school. He was having wedding accidents. For him, he had a bad thought OCD presentation. The primary symptom was seeing images of kids he did not like in the hallway of school. He actually visually had kind of what would seem like hallucinations, but he would image these kids. And then he'd see them on his homework and his paper at school. And that's why I called you about this one, because I hadn't had that before. He actually thought he saw the faces on the paper. But we did boss back. It's a brain trick, annoying but not dangerous. He liked that. A thought is just a thought. And we did the usual exposures. Wherever he thought he saw the image, we walked on the image. We kept writing over the image. We broke all the rules. We wrote the names of the kids he thought he might turn into. And what his parents and his teachers said at school, if this kid was feeling well, he was back to his old oppositionality of always saying no to whatever they asked him to do. When he was ill, he was really dysregulated, really silly, and couldn't focus. And so he like Tamara said, he really could not work well despite wanting to and getting in trouble all the time. It was really bothering him. And we had to start very small with very 10-minute periods to start limiting rituals at home because he was reporting, confessing, avoiding the whole time. His parents had been really great and working ERP strategies for about 1 to 5 months when we saw this exacerbation. At that time, in consultation with psychiatrists, we also began Zoloft at 12 milligrams and slowly increased because he had such extreme anxiety kind of prior to the PANS. You'll see one thing in the article, really important, that the SSRIs can be helpful, but you begin low and go very slow. Right. These kids are highly sensitive to side effects and others, so they can be really helpful.
Quarter of the dose
to
start.
Yeah, quarter of the dose, and so often also psychiatrists don't know that, and they start high and the kids get really dysregulated and they have side effects. He did much better. The Zoloft really helped. At 37.5, we went up to. And with treatment, he had bouts that still occurred, but they lasted less time and were less impactful. He'd have like 3 days or so. We were very fortunate. This is a private school that we worked with for kids with autism spectrum, and they were willing to do all the treatment also in school with him. I would give them the boss back language, and they'd send him down the hallway to walk on the images, and they knew he was struggling on his schoolwork. So they just said, a thought is just a thought, go forward. So luckily, we were really able to get him better pretty quickly. He did really well after 2 more months of treatment of the exacerbation. I saw him for a booster as needed with flares over the next year, but it was 3 times a year just for 1 session to remind him to get back on track on his OCD. And he has not needed treatment for 2 years, and he's doing really well. What's our time? We have a few more minutes. I'll just say this is another one that surprised me. Again, I called Tamar because this was another one I hadn't seen. A mom who was a physician had felt that her child had PANS, though I didn't believe it, truthfully, when I heard the presentation. But he had, when I went back over it in more detail when we had the trouble later, he had a 2nd grade kidney infection that had really bad OCD with showering and nausea. He improved with antibiotic treatment at that time for the kidney infection. And then it turns out, again, she hadn't told me, he had gotten strep 5 times in 1 year. But he didn't have OCD increased with that strep. So yeah, he's an interesting one. And so for me, the severity level was not high at presentation. It seemed like usual OCD. He had moderate symptoms of bad thought OCD. That felt like my usual bread and butter. He had some hand washing and sanitizing. But at intake, mom had said, and I always trust moms, but I didn't trust this mom as much as I should. She said he's really not himself. He's more anxious when he's usually a laid-back kid, and he is a laid-back kid. He's not a worrier. Mm-hmm. He has got nothing. He's more easily angry, and he talked about being fatigued all the time. But he wasn't feeling too bad overall. And so, again, I'll jump ahead. This kid was not very collaborative with treatment, though he was a good kid. He was mad, he was feeling bad, but he did not want to make or follow any plans. But he did take in the overall approach and was using OCD ideas and strategies to delay or limit rituals to some extent to get some relief. The family was doing a ton of accommodating, and they were very reluctant to change because of the parent anxiety and the concern about him being ill. They wouldn't almost do the OCD treatment as fully because they felt so bad that he was ill, and it was problematic. So the last thing I'll just say that made me realize how much PANS was part of it, we started to see periods of intense and then less OCD, and it was not linked to strategy use or stressors, but it was linked to how he was feeling physically. Mm-hmm. And he got a regular virus that required antibiotics, and wouldn't you know, he got better, and his OCD was tons better with the antibiotic. But 1 week after finishing the 2-week antibiotic course, he was bad again. And then his mom noticed a rash on his arm that was atypical, radiating up to his lymph nodes. And she does dermatology. So she knew that was trouble, that he had an infection. And so that led us to, and he got worse, of course, with this radiating rash, which again is a PANS presentation I did not know about. He was treated on 3 months of prophylactic antibiotics and much better. He had some residual low level of symptoms that he's ambivalent about addressing, right? And hasn't, but also way better. And I have not seen him for close to a year. And I don't think we have time. Astrid, can you help us? I'm not sure. Do we have time to do a little bit more on the school
questions?
Yeah, because we had.
I think we can.
5 more minutes?
Yeah, I think we have a little more time. I don't have any other questions for now.
Okay. Great. Well, this was important, I think. So working with school is almost always important if there's school-related symptoms for anxiety and OCD, and I think a lot of us coordinate with schools, but it's really important that the family have an advocate with school. Our goal is to advocate for the child with the parent's permission. It's very important to know, and I've helped, and Tamar has helped a lot of schools really work with us. You almost have that bimodal need and plan based on the child being ill or not ill. Right. So if the illness is severe, either at first presentation or exacerbation, really some children can't attend school at all, or they need a shortened day, short-term home-based instruction. We always try and keep kids in school if we can. And so sometimes we work with being in class and not doing any homework, some other milder modifications. But some kids are so inattentive, so restless, so agitated that they can't be there.
Right. From the neurological,
right?
Yes.
Right.
Repercussions.
So the child might be unable to complete work at home because of impulsivity and inattentiveness. And we need to help schools understand that this is a medically based exemption, like surgery or recovery or a chronic illness. It's even different than what they do for anxiety and OCD because the child is so physically ill. We almost, as I say, might have two patterns on the bottom of their little or no accommodation needed for well periods. And it is important to get the child back to regular functioning if they're healthy again. But we need clear modifications and plans for ill periods. And sometimes if there's a kid with repeating recurrences, which is still, the more typical for a while, right, is that you're likely to have some kind of recurrence. We want to plan for that ahead of time, and it may be the child catches up on just essential work, has more frequent breaks, has some extended time, has the time to go rest, in the nurse if the whole school day is too long. Some of the more typical things we might do for a bad case of OCD and or anxiety, but it's, again, illness based. So I think we don't have too many more questions, except tomorrow. I don't know if you want to speak a little bit to the other approaches, non-antibiotic, if there's research or knowledge about, the overall immune system and other things. And these are some of the resources for you.
I actually received a few questions just now. I'll read them out loud. I have seen parental accommodation in kids with PANS being much more difficult than kids with OCD. Anything special you say to parents to help them do exposure, not accommodate?
So my question would be, is the child capable? Is the parent accommodation warranted? I was going to say that we've talked about cases today where we could do CBT and the medical treatment simultaneously. I have had plenty of cases where really it's like Lynn was saying, that if you had a child with a flu, you probably wouldn't drag them into treatment or expect much of them.
Right, for sessions.
So there are times when the medical piece has to be addressed before the child has any kind of control to do something different. So, if that's the case, that, this is, you have to deal with what's going on now. If there is the reluctance that we see in other, OCD or anxiety situations where the parents are afraid of hurting the child, setting limits, making it worse, stressing them out more, that's the place where we have to say, look, neuroplasticity works. You can be part of this, help by your responding differently. You're not being mean. You're never withholding. That's not what it's about. Like the good lines that Lynn had earlier, to say, I know this is hard, but this is what's going to help you, and I'm here to help you with that. We want you to get stronger, not the OCD. So those kinds of statements.
And I felt I've had to test it out with parents and kids' permission. I'm not sure what you can or cannot do. Can we try this, or what can you do? You can even ask kids, what can you do and what's impossible to do?
Yeah.
And so we want to functionally do our assessment. Is the accommodation out of the parent's anxiety or beliefs that they're making it worse, or that they'll, or the kid will rage, right? Or what's the reason for it? But often in these cases, again, we've had to almost hold and support the family through the period of waiting for the kid to get better, and knowing that it's okay that they can't do anything, right? So our goal is sometimes that, like, because parents are like, what do I do? What can I do? And you're like, your kid is really ill. We're just going to try and help the family function as best as we can for these 2-3 weeks while we get him better, because then we can do others. What is impacting your family? What's happening day to day that we can think about and strategize about, right? So I think it's more, it's always complicated, but this is an additional thing that you have to bear in mind that's different from your usual cases.
And it's maybe more about initially family functioning. than the hierarchy of OCD symptoms as we would
Right.
normally do with, a straight OCD case.
Okay. Did you say you had other ones, Astrid?
Yes, we do. So
Okay.
the next question, have you ever seen an adult who developed severe anxiety following an illness in childhood and was found to have PANS?
We've gotten referrals for adults. I
You
haven't.
wanna-
I don't know the answer to that. I've wondered because people ask, but I have not had it.
Do you mean sort of retrospectively? I have had adults who said they think that this happened to them,
Yes.
and it was not, obviously not identified as such at the time. So yes.
But it usually doesn't so much matter for the current treatment, except awareness of one's history
Right.
matters for everybody, unless there's some kind of can PANS seesaw though appear in adults?
So there have been some
I don't-
reports of this kind of sawtooth pattern, as Lynn was saying, a spike when it's an active episode and then almost a complete recovery or a complete recovery. There have been reports of that with adults, but it's more rare because just antibodies to the most common culprit of strep, build up. It still is possible, but that is, as much as PANS has not been studied enough, that has been studied less.
Right, and I think it depends where you live. Also, we live in a high-tech area, and we've had a lot of cases that are the Lyme-related or the parasites on Lyme. They test now for parasites that are on deer ticks, and we some of my cases have been families that live in a more rural or area where there's a high deer population, and so they're just more at risk for Lyme overall and have to watch. Yes, so.
It's possible.
It's possible, yeah. But again, there was one other question we didn't answer. Astrid, do you have another one so we can just?
Yes, I do. I have a couple more.
Okay, do we have to end at one?
It's okay if we go a little over.
Okay, that's all right.
Well,
with us, okay.
Will a PANS child always have exacerbations with illness, such as, is this a lifelong issue?
Okay. Yeah, great question. So what tends to happen, what tends to happen is different things. There are kids who truly have an episode, they get treatment, they get better, don't hear from them again, or hear from them.
We've had a significant number of them.
That is the majority. And we probably are selected for tougher cases
Yeah.
in a way, just because this is our specialty. But I want to say that the majority of these cases, somebody gets, child gets treatment, they get better, that's great. Other kids absolutely will go on to have repeated exacerbations, but again, they've got their team together, treatment happens right away.
Right.
The sooner the treatment happens, the less the inflammation, the less all of the neurological and behavioral sequelae, and so the whole episode is just much more contained. And it does seem, though I don't know, I think there's a little bit of long-term studies that have been done, but obviously more of that needs to happen, that there is a point where kids, they have the antibodies to these different conditions and they're able to, they don't continue to have flare-ups. I have a kid now who's a college student who had several PANS episodes, needed to be hospitalized when he was in middle school and even high school. But he has been in the clear for many years. But that's just not, I'm sure he's had a lot of exposure to germs, but that's just, his body is not responding that way.
But part of the education for families is to have a low threshold. Sometimes certainly if symptoms jump up, to do their strategies right away, and then sometimes to test if there's a reinfection of strep. So they have to kind of know to go to kind of check things out. Right, if you see the sudden exacerbation again,
right.
And
the more typical case too, which we didn't talk about, is where a child goes for treatment quickly, has 85% improvement, and then has the leftover, what I call sort of echoes of OCD. Parents are so relieved that the child's doing better.
Right.
Child's so relieved that they're ready to move on. And I say, we've got to work on those echoes. That's when you really do your pretty straightforward CBT for OCD to help them be able to tolerate the uncertainty of not checking, not doing rituals, because we don't want them to be marching towards having a diagnosis of OCD.
All right. Dr. Chansky and Dr. Sicklin, do you have any time to answer a few more questions? I did receive quite a few.
Yeah, we do. Also, one that came up that we skipped over is, have you ever seen PANS present? I haven't, as selective mutism all of a sudden, not speaking at school or home.
Mutism.
I mean, more just not speaking anywhere as the presentation. I haven't.
I have not seen that, but you know that it's entirely possible if
it had
that
a medical
came up, if you know, suddenly like that, because
yeah,
selective
that doesn't usually come up
mutism
suddenly.
is more of a gradual, you know, process anyway. So I would basically any sudden change, you know, go back to that exact date disorder idea, that any sudden change in behavioral symptoms, that it would make sense to consider PANS as the rule out for sure, because let's face it, that's not, you know, except for in the case of trauma, that would not be the typical presentation for anxiety disorders or depression.
I would say for the person who asked about the kind of natural and other systems, there is a really good review in the guidelines that are listed here of the research, and there are some other things that people are looking at to help with immune functioning and inflammation.
It's more about, it's a lot. There was a study that found that, I think it was treatment with vitamin D reduced the occurrences of strep infections by 1/2. But again, something like vitamin D, you know, that would need to be monitored through a physician, you know, because that is not water soluble. You need to make sure that you're dosing appropriately. But yeah, in one of the 3 articles,
they review all
treatment.
Review all the treatments.
That is there. It's really worth looking at that.
Yeah. You can fire away. Astrid until.
Okay. Our next question: what if the child is suicidal? Do you still do CBT?
Do you want me to?
Yeah, you go ahead.
Of course, you know, if a child is truly acutely suicidal, whatever it is that you know, one does to ensure safety for a suicidal child, probably hospitalization. But generally, I'm going to say, in my experience with many cases, that is not the presentation. So I'm sure that's possible, but it typically that is not what I've seen.
Or it might be due to a comorbid condition along with PANS.
Sure. Yeah. But so, as you know, if I would ask that question in any context, you know, as determining how the child's safety is obviously number one. Medication, you know, would be introduced likely at that point, or possibly a change in level of intervention.
Yeah, and as I think you all know, I think this is too hard a question to ask, but we have a lot of kids who are dealing with suicidal thoughts, and issues while in treatment for OCD, and we can, with their permission, go forward with exposures if they're not at acute risk. It's an assessment of the risk. At acute risk, no.
And a whole other question, which we might do another webinar someday, is about how kids with OCD can have an intrusive thought about killing themselves and not be suicidal. They experience those thoughts as, you know, ego dystonic, we could say, that it's not how they feel, it's not what they want to do, but they need to know what to do with those thoughts.
All right. I think we only have time for one more question, but I will forward all the other questions to our presenters after this presentation. So our last question for now: are there randomized controlled trials showing that children with OCD or anxiety disorders that is thought to be due to PANS get better faster if they are treated with antibiotics or IVIG or anti-inflammatories, as well as ERP and SSRIs, than if they are treated with ERP and SSRIs with no medical intervention targeted at PANS?
Eric Storch in that group has done some work, but I don't think there's a clinical trial of that. But I don't know.
And sorry, I can't quote this, but there is a study that was more a, it's not a randomized
Right.
trial. I don't think that would be ethical
Right.
to do, given the medical piece, which it's clear that inflammation is shown on MRIs and such. So there would not be that comparison, but there is. I thought it was Susuito, but maybe it's Storch, that looks at sort of the outcome of kids who have intervention with antibiotics and
yes, that was interesting.
and steroids, etc. And they're good. Generally, they're really good outcome.
Right.
It's important to know.
I think it's more at the level of this resource here. There was a survey, which is fascinating, of 700 families.
I think that might
with
be
their presentation, and it outlines all the treatment used, and it was really really interesting and helpful. But I think that's the level it's at. But because we just want to remember, because it's a medical condition, it's unlikely there to be a study that would deny medical treatment. Right. Right.
That the indicated medical treatment for inflammation is, steroids or IVIG or plasmapheresis. So.
But thank you all for your great questions. Yeah. And we really like putting this together. Tamara's talked about this quite a bit, but I'm part of this special interest group in child anxiety. So please join us if you're interested. We do talk about these cases on our case conference, and there's just a lot of interest. So if you want to follow up, please join that group. It's monthly case conference, complex cases and clinical issues. So that's a good place. And thank you very much.
Yeah, thank you.
And thanks to ADAA for hosting and asking us to do this.
Thank you.
Okay.
Our next ADA webinar is titled How to Manage Family Accommodation in Child Anxiety and OCD, an interview with Dr. Ellie Lebowitz on Wednesday, February 12th at 12 p.m. If you're not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ada.org to learn more.